Thank you, David. It's my pleasure to present this interesting case. An alternate name is also the Lone Star case. So I'm going to go through this, spend a little bit of time on the history. There are quite a few details that I want you to catch in the ultimate diagnosis. So this is a 59-year-old female who presents with chest pain around September, very strong pleuritic component. And 3 months prior, she had been in Texas, hence the Lone Star case, and was diagnosed with a pericardial effusion over there. She had a window, and according to the patient, 500 cc's of bloody aspirate was taken during a diagnostic pericardiocentesis. This was ultimately felt to be viral in nature. She was discharged home on ibuprofen. So this is about 3 months of presentation. 1 week following that discharge in Texas, she presented to an outpatient clinic. She was having worsening pleuritic discomfort, and she was changed to indomethacin with a future echo arranged. She had a subsequent emergency room visit for chest pain, diarrhea, shortness of breath. She was diagnosed with recurrent pericarditis. She's placed on colchicine and ibuprofen and sent home. So this outpatient echo is still kind of looming in the background. It hasn't been done. And on just hearing her story, the caregivers involved switched some of her anti-inflammatories around. She presents once again, however, this time her dyspnea is extremely worsened. She has new onset of orthopnea, fevers, chills, and dysuria, resulting in a return to the ER. She comes to the emergency room in London. Her temp is 38.6. She's tachycardic. She's otherwise slightly hypertensive to normotensive. Her respirate rate is up, and her saturations are down. This is based on a resident assessment. The KVP was apparently not visualized. There was no significant pulsus paradoxus. She had reduced breath sounds bilaterally. She was quite dyspneic, impressionably to the resident. Her investigation showed a mild leukocytosis. Some of her LFTs were mildly increased. Her CRP was 153. She was cultured twice, and these would ultimately be negative. Her troponin would be negative based on the assay in London. Radiographically and clinically, she was felt to be in some element of heart failure. And so she was admitted to cardiology, and they wondered about possible constriction given her recurrent pericarditis type symptoms. I didn't show her ECGs. They didn't look classic in a pericarditis sense, but the query was made regarding possible. She was admitted for further workup. So I'll start by showing you some images. I have to say she had very technically difficult windows, and I'm not showing you the entire study. But you can see here that there is a pericardial effusion with some organization in her pericardium, and potentially mass, potentially just organized. It may represent some fibrin, but it's small. Her LV function looks good. We have a lot of trouble in this echo seeing her right-sided structures, her RV and her RA. So short axis, her LV function looks reasonable. The septal motion looks reasonable as well. And we do see this organized collection within her pericardium. So just some brief diastolic constrictive assessment as was done by Dr. Ju earlier. You can see that it really doesn't hit the criteria for respiratory variation. Her IVC is, shows some collapsibility, doesn't quite measure above 2.1. It's indicative of an intermediate right atrial pressure of about 8 millimeters based on contemporary guidelines. Her echo report, basically there were no significant valvular lesions. Overall, her LV function was reasonable. Careful to state that the RV could not be adequately assessed due to poor image quality. There was mild aortic valve sclerosis, and the pericardium by our particular reader on this day was addressed in the following fashion. Small pericardial effusion with increased pericardial space suggestive of organized pericardial effusion. No echocardiographic indications of hemodynamic compromise. So during her admission, she did have a D-dimer that was positive, as had also been positive in Texas, we would ultimately find out, and she had a CT pulmonary angiogram performed. And I don't have the images, but the results suggested a nodular thickening of her pericardium with some apparent mass-like thickening and nodular appearance to the right atrium. It was negative for PE. The mention was made that an infiltrative neoplastic process is not excluded, and they suggested some correlation either with further echocardiography or cardiac MRI or subsequent future imaging. Here's a cardiac MRI, and the arrow sign is basically showing the soft tissue density involving her right atrium. It measures about 4 by 3 centimeters. And in the report, and you can see her pericardium here, it's very thickened and nodular in nature. I won't go through the entire report, but basically there is mention that it's about 4 by 3 centimeters. It appears to be partially encasing the RCA. The radiologist also looked at a CT that had been performed and found some internal hemorrhage on the CT exam seen within the lesion in keeping with local enhancement. And it was unclear whether this was primarily from the pericardium or the myocardium. The pericardial findings included thickening and nodularity with hemorrhage. It raised concern for possible tumor invasion of the pericardium. And there were some other, and it did suggest constriction in terms of decreased end diastolic filling of the right ventricle. So, with this MRI known, the patient was an inpatient, and a few days later, her echocardiogram was performed. There was mention and visualization of that right atrial mass or tumor, which we do not see on the transthoracic. The RV free wall is once again poorly visualized. There does seem to be a little bit of that late end diastolic bounce that Dr. Ju had nicely described in his talk, now apparent on the short axis that didn't seem so prominent on her previous echocardiogram. On this current echo, there is evidence of significant respiratory variation in her transmitral Doppler flow. And if you look, her medial E prime is slightly higher than her lateral E prime, possibly suggestive of annulus reversus. So on this echo number 2 report, all other things being relatively equal, the big finding is this last comment that compared to the previous report, there is evidence now of pericardial constriction. This is within a few days of admission. So when you have a patient sitting on a cardiology ward, what often happens? Well, they get a cath. So here we have a cath, and interestingly enough, you can see that although there is no significant coronary artery disease, when we look at the spider view of her left coronary artery, notice how relatively stagnant and fixed the proximal segment is. Similarly, we had an MRI that had suggested encasement and possible infiltration of her right coronary artery, and look at how fixed, once again, the proximal segment is of the right coronary artery. So our angiogram report comes back with no significant coronary disease. However, there is noted mention of the restricted motion of coronary arteries secondary to possible fixation of the epicardial vessels to the pericardium and mass. So I'm presenting this case in real time as it was evaluated in London. And roughly after the angiogram was performed, we were ultimately, or the team involved in her care was ultimately able to get some of her files from what was done in Texas during her brief admission there. So in Texas, in summary, she had a D-dimer that was positive in the ER. She had a CT-PE that revealed a pericardial effusion. She had an echo suggestive of a large circumferential pericardial effusion with no tamponade physiology. For diagnosis, 500 mils of bloody aspirate was obtained. The fluid results were available, and they came back relatively benign. She had a pericardial biopsy that was benign, suggesting chronic inflammation with no evidence of malignancy. And her cytology demonstrated benign mesothelial cells in the background of mild, predominantly chronic inflammation with no malignant cells, but once again, a very small sample of about 150 mils. So at this point, we have this lady on the ward. She has a significant mass in her RA, and she has evidence of constriction now by echocardiogram, suggested by MRI, with a very abnormal pericardium, and she's symptomatic. So a plan is made to take her to the OR for pericardiectomy as well as resection and ultimate sampling pathologically of the right atrial mass. Her preoperative TE does actually show the mass in her right atrium. This is a bicaval view for those of you not familiar with TEE, the IVC and the SVC. This is around the right atrial appendage, and we can see the masses here. So intraoperatively, what happens? Well, there's planned pericardiectomy and RA mass resection. The intraop findings include hypervascularization of the pericardial fat, severe pericardial adhesions with thickened pericardium, very difficult to open, and there was a vascularized mass covering the RA and the RV. The origin wasn't well known, as well as RVOT and ascending aorta. So frozen tissue histopathology ultimately would reveal what? Not a hard-boiled egg. Unfortunately, this was angiosarcoma. So a decision was made intraoperatively at that time given the extensive nature and infiltration of the right atrial mass and the prognosis associated with likely a primary angiosarcoma. As I did not mention, she did have full body imaging, CT, chest, abdomen, pelvis, not showing any evidence of any other primary site or solid organ tumor. And given the known poor prognosis with the anatomical extent of the actual right atrial tumor, a decision was made to not proceed further beyond the frozen section that was taken. And the lady was taken out of the OR, and a plan was made to consult medical oncology, and unfortunately, she passed away about 3 to 4 days after this intra-op. After she was taken to the OR. We do have some nice images intraoperatively, and you can see how abnormal the pericardium appears, hypervascularized with a lot of local hemorrhage. You can get an encased nature of her pericardium, so it's a very nice images taken in this unfortunate case. So the diagnosis in this case is a primary cardiac angiosarcoma, and these are, as has been sort of alluded to in previous talks, relatively rare. The risk factors include exposure to vinyl chloride and potentially a family history. This is from a paper in Circulation 2005. The clinical manifestations, oftentimes, as with many cardiac tumors, the patient may be asymptomatic until it is very advanced in stage. They can present with symptoms of heart failure or embolic phenomenon or pericardial effusion, as was bloody in her case. They can have tamponade or constrictive physiology. And typically metastatic disease, almost 75% is evident at presentation, commonly lungs, liver, bone, spleen, and brain, etc. So for primary angiosarcoma, this is a case series from a pathology journal showing that the primary site is often the RA, and you can see here in this case summary of the literature, the RCA can be encased, in many of these cases, and the primary location is the right atrium. For metastatic disease, for those who had METs, these can go either to the liver, the lungs, the brain, the anterior mediastinum, the SVC. Pathologically, there are typically these atypical pleomorphic spindle cells with poor mitotic figures. Non-invasive imaging is crucial, and we really need to use, in a case this complex, all of our multimodality friends in order to really delineate the anatomy and the amount of invasion and to plan for potential surgery. This is what Jonathan had mentioned in his talk, the finding of late gadolinium enhancement showing central necrosis in a patient with cardiac angiosarcoma. The TE finding in this one paper is similar to what we saw, though you can see it is more adjacent to the IVC, whereas the tumor in our particular patient was close to the SVC near the right atrial appendage. The treatment is surgical resection, but even with chemotherapy and radiation, the prognosis is very poor with or without chemotherapy, typically looking at a 6 to 12 month survival. In terms of cardiac transplantation, it is associated with significant recurrence as well as poor outcomes. I'd like to just acknowledge Dr. Andrew Thane, our current ECHO fellow, who helped me with this presentation, as well as Dr. Basil Al-Sabiq, one of our C2s in London. Thank you very much.